Welcome to this episode of Sleep Health in the Restonic Power of Sleep podcast channel. I'm Dr. Alison Bentley, and we're talking today about the basics of insomnia. So we've spoken in this series about a lot of things to do with insomnia. We haven't spoken about what it actually is and where it comes from and what the common causes are. And that's often questions that I get asked. And particularly, where is the line between normal changes in sleep and insomnia? Like, when does it become a problem? So we're going to start right there, and that is with normal sleep. Like, what is normal sleep? If you Google normal sleep, it will tell you that it's 7 to 8 hours. And that's not entirely correct. It's certainly true that the majority of people are going to sleep 7 to 8 hours per night. But that means that 7 to 8 hours is the average, not the normal. And so, like every parameter in the body, if you go and get blood tests taken, thyroid hormone, iron levels, for example, it will tell you that the normal range is from here to here. And that's different for each of these parameters. And so the normal range of sleep can be from 4 to 9 hours. So there are lots of people who sleep 4 hours per night and don't have insomnia. We'll get into what those differences are in a moment. So let's look at duration. So that's the duration of sleep. How long do you sleep for? And then the quality of sleep. What is the quality? What is a normal quality? And that's much harder to define, because people define quality of sleep in different ways. They will talk about the quality of sleep is that I didn't wake up during the night, or the quality of sleep is that I woke up feeling refreshed. So quality of sleep can be a bit tricky to define what the normal is for that. But really what we would say that normal sleep is that you get enough hours of good quality sleep to wake up feeling refreshed in the morning, and that you don't feel sleepy during the day. You don't feel compromised by a daytime dysfunction, i.e. poor concentration or poor memory or poor attention, or you're not falling asleep in meetings, particularly those ones on Teams or Zoom, and you're able to function during the day, and a sleep deficit doesn't interfere with your daytime function. So that's what we would call normal, and normal can look different for different people. So normal can look that sleep happens in 2 pieces at night. Normal can be that you only sleep for 5 hours, but really good quality. Some people need 9 hours. So there is quite a variation in what normal is, and so it can be quite tricky to define what's the difference between normal and abnormal. But I want to backtrack a little bit and talk about what controls sleep, because I think if we understand what controls sleep and we do have difficulty with sleep, it makes it a lot easier to look at how we can manage that sleep that's gone wrong. So to start off with, there are genetic constraints on sleep. Sleep is a very biological thing. And there's this wonderful saying that says humans are the only species that can deliberately stop themselves from sleeping. So your cat or your dog never has a problem falling asleep, just never does. And the difference between them and us is obviously we have this kind of mind component that is independent of biology. But it's really important when we talk about sleep, and particularly when we talk about insomnia, that we understand the biology of our specific sleep, because it may be different to your bed partner who is sleeping like a log and you can't sleep. So the genetics of sleep. One is this biological need for sleep. And we found genetics or genes in the fruit fly that determine how long fruit flies sleep. So you can understand that that is a genetic thing. And if you're designed to sleep for 5 hours and your dad only slept for 5 hours, but that's a genetic constraint, you're never going to get 7 to 8 hours. And so you need to be very careful that you don't buy into that 7 to 8 hours is the only normality as far as the length of sleep is concerned. So genetics, how long you're going to sleep for, and then genetics also about where your sleep is positioned in time. We call that the phase of sleep. So, for example, there are 2 main phases. So you'll see, if you go on Google and look at phase of sleep, they'll tell you there's 5 different types of people. We kind of only really talk about 2. And one is the larks. And these are people that go to bed at 9 at night and they're up at 5, super cheerful in the morning, off to gym, but they're the party poopers. If you take them to a party at 9 o'clock, they're kind of going into themselves and can I go home and go to bed? So those are the larks. And then there are the owls, and those are the party people who can stay up till 1, 2 o'clock in the morning and are never going to be at gym at 5:30. They're going to sleep until 7 or even later if they possibly can. They're the ones who more likely are going to go to gym at 5 o'clock in the afternoon. But many people sit in the middle, and they're neither. They're neither strong larks or strong owls. So how do you know you're a lark? Is you know that you're sleepy at 9:30 in the morning and you can't sleep past when the sun rises. So you're up early in the morning, and you would always describe yourself as a morning person. I get my best work done in the morning, and then by the afternoon I'm fading a little bit and I'm not strong when it comes to working in the evening. If you went to university, you are the person who gets up at 4:00 in the morning to study before the exam. How do you know you're an owl? Because you can keep going at night. So at 9:00, when the larks are kind of packing up and putting themselves to bed, you're in a situation where you're saying, what can I do for the next 2 hours? So can I work? Can I watch movies? Because I'm not sleepy at 9:00 at night. I only get sleepy at 11, 11:30, 12:00 at night. You also, at university, you were also the person who would study until 2:00 in the morning. You're never going to wake up at 4:00 to study. You're also the person who is going to wake up in the morning at the last possible moment to grab breakfast on the way out the door and get into your car and go to work. You're that person. The morning person, the lark, is going to get up at 5. They're going to plan their whole day. They're going to plan their lunches. They're going to pack lunches. They're going to have a proper breakfast. And they're going to have plenty of time to get themselves ready for the day. And most people can identify with one of those two, what we call chronotypes. So chrono is clock, and the clock types. And so you're either a lark or an owl. And that can be set. That can be genetic. I'm very much a night owl, and I'm that person at 9:00 that starts doing admin because I'm not sleepy at all. And I did have to get up at 5:30 every morning for years to get my children to school. But the day my youngest child could get herself to university was the day I slept through till 7. And I'm much happier if I can go to bed between 11:30 and midnight and wake up at 7. That is where my best sleep sits, in that kind of time zone. And it's really important to know that about yourself, because if you have insomnia and you're trying to sleep at the wrong time for you, understand that you will never be able to sleep really well and really satisfactorily if you are sleeping outside of where you should be sleeping, as far as your genetics are concerned. So for genetics, understand for yourself how many hours you need, not how many hours you want. I have a big problem with retired people who kind of go, well, now I can have as much sleep as I like. And I kind of go, no, you can't. You need to sleep how much you need to sleep. Just because you can now go to bed earlier and you can now wake up later doesn't mean that that's appropriate for your sleep. So understand what your need is for sleep. Is it 5 hours? Is it 6, 7, or 8? Could be 9. And then find out where in time your best sleep is. So that's the genetics of sleep. Then we look at the biology, and there are 2 biological factors that you can manipulate. So understand genetics you can't really change. That's who you are. But biology is what you can change. So there's 2 biological factors that help us fall asleep at the right time. One is something we call the homeostatic factor, and really that's really very simple. Sounds very posh. Very simple. It just says the longer you stay awake, the sleepier you're going to get. And that's really important when it comes to sleep. So if you, and I always kind of visualize it as a credit card that you're spending on during the day. And then when you go to bed at night, you pay it off. And you wake up in the morning. Unlike our credit cards, you wake up in the morning and it's been fully paid. And you start at 0 again. But you can understand that if you pay it off halfway during the day and have a nap of 2 hours in the afternoon, then when you try to go to bed at night, that credit card is not groaning. It's not fully maxed out. And so you may have difficulty falling asleep at night if you've paid off some of it. So when you want to fall asleep, if you're looking at how do I make sure that I'm really sleepy when I go to bed, spend more time awake. That's the homeostatic force. The second force is melatonin. And I'm going to do a whole episode on melatonin because it's really important. But basically what it does is when you're exposed to dim light at night, the melatonin is secreted in your brain. And when that melatonin rises high, what happens is you have a drop in your body temperature. So it kind of forces the body temperature to go lower. And as that body temperature is dropping, and it can be 0.5 degree to 1 degree, as that body temperature is dropping, that's when you're going to feel sleepy. So it induces that big sleepy effect. Melatonin, the body temperature is going to stay low the whole night, and then it's going to kick up in the morning again, and that will be your natural wake-up time. So the melatonin kind of times when you're going to feel sleepy and when you're going to want to wake up. Okay, so then we add on to that the neurochemistry and the chemicals that are in the brain that actually will induce sleepiness and which will induce wakefulness. And I'm not going to go into a whole hour long about all the chemicals in the brain because there are literally books that have been written on this. But understand melatonin is the big one to put you to sleep. The other chemical that's involved is GABA, and that's what all of the sleeping tablets work on, is GABA. And then there's another one called histamine, which keeps us awake. But the antihistamines are the other medications that we use, and those, the ones that you get over the counter, for example, at the chemist, are antihistamines, and they put you to sleep. So in summary, the three kind of chemicals you have that help you fall asleep are melatonin, antihistamine, so working against histamine, and GABA. So those three are the ones that put you to sleep. Then in the morning, there's a big hormone, a big neurotransmitter that comes in called orexin. And it's the neurotransmitter that keeps you awake the whole day so that you can stay awake the whole day. In fact, if you lose that orexin, then you get narcolepsy. So that's how important it is. So it stays awake up for you the whole day. And it's really important that you have this change that happens. So melatonin kind of increases at night and puts you to sleep, and this orexin disappears. And then during the day, orexin is high and melatonin is low. So it's important that you have these two moving against each other. So that's the chemistry that's happening behind falling asleep. So then you have all of this happening, and then at night you kind of want to fall asleep. So it is important that you're falling asleep at the right time, both for your genetics and duration of sleep and the genetics of being a lark and an owl, that your melatonin has been produced and that you have been awake long enough. So it sounds really complicated, but most of the time we just do it naturally. We just kind of go, I know that my bedtime is 10 o'clock. I know that I need to be awake from 5:30 in the morning to be sleepy enough at 10 o'clock. And I know that I'm going to be exposed to dim light before 10 o'clock. And most of us do it naturally without even thinking about it. But the process of insomnia means that all of this can fall apart, and then you kind of got to get this all aligned again to be able to fall asleep. So normally what you would do is go to bed at a particular time, go brush your teeth, put on your pajamas, maybe read a book or so, feel nice and sleepy, and then go off to sleep. But if we have to kind of take it apart and say, what do we need to be able to fall asleep? Number one, you have to be sleepy. That is the most important thing. If you are not actually sleepy, the chances of falling asleep just go down. So you have to be sleepy. So you have to figure out this kind of combination of when do I need to be able to go to sleep. You've got to be sleepy. You have to be safe. There's no question. If you're feeling unsafe, it's going to be difficult to fall asleep. You need to be comfortable, and then you need to just let go. And that is what goes wrong with insomnia, is that ability to just let go. Or it's about the fact that I'm not sleepy. So insomnia really comes up where we have people who are not sleepy and are trying to fall asleep, or they are sleepy but they just can't let go and allow that biology to happen. So that's what's important. Remember, be sleepy, be safe, be comfortable, and then let go. So then that's how your normal sleep works. Right. So what is insomnia? So insomnia, by definition, is that you do not get enough sleep at night to have adequate daytime function during the day. It's really important that there is a dysfunction during the day. And this is what separates naturally short sleepers from people who have insomnia. So there's two groups of people who are sleeping 5 hours a night. There's the group of people who genetically can only sleep 5 hours a night, and they sleep 5 hours and they function perfectly well during the day. Those are naturally short sleepers. Often they have a family history of people in their family who don't sleep a lot. So people who go to bed very late, still wake up very early, and they don't have insomnia by definition. The other group of people are people who are sleeping 5 hours a night and know every minute during the day that they have not had enough sleep, that they actually need 6 or 7, that they are short of sleep during the day, and that dysfunction is what alerts them to the fact that they're not having enough sleep. That's insomnia. Insomnia is not that you have no sleep at all. That is not insomnia. Insomnia means that you have too little sleep. So, how does that present in real life, and how does it present in patients who have insomnia? So you can either, there's a lot of different types of insomnia. So the one type is defined by what the symptoms you have of insomnia. So there are 3 main symptoms. One is that you have difficulty falling asleep. So everybody knows what that feels like. I think we've all had one night or so that we've had difficulty falling asleep. And that is, you go to bed at the right time and you feel sleepy, and then you just don't manage to fall asleep. Either you have had a stressful day or you have a stressful thing coming up, for example, exams. So everybody's experienced, I think, difficulty in falling asleep. Not everyone has experienced waking up in the middle of the night and then having difficulty going back to sleep. So waking up at 1, 2 in the morning and not being able to go to sleep until 4 or 5 o'clock a.m. And a third group of people have difficulty sleeping until the right time. So they're very aware they need to sleep from 10 until 6, and they go to sleep at 10, but they're waking at 4, and they're not able to sleep those last few hours. So we call the first one initial insomnia. We call the second one, where you wake up in the middle of the night, middle insomnia, obviously. And then the last one is very unfortunately named, but it's called terminal insomnia. It doesn't mean that you're going to die or that the end is in sight. It just means that the problem is at the end of the night, that is where you have insomnia. So 3 different types. It's very unusual for people to only have one symptom, i.e. only have difficulty falling asleep. They often have difficulty falling asleep and unrefreshing sleep, or they have difficulty falling asleep and they're waking up in the middle of the night. So it's more usual to have more than one of those symptoms. And usually having those symptoms themselves don't mean anything specific. So it used to be that we would say that if you have difficulty falling asleep, that's anxiety. If you wake up in the middle of the night, that's depression. But seeing as depression and anxiety now are very closely linked, it's very unusual to just have one of those symptoms. And often you have many of them. So don't be bothered if you have multiple symptoms and you can't define what the cause of the insomnia is. So also importantly is to understand that difficulty falling asleep may be completely normal if you're trying to fall asleep way before you're actually meant to go to sleep. So I know that I would have difficulty falling asleep and insomnia if I tried to go to bed at 8 o'clock at night, because my bedtime is at 11 o'clock or 12 o'clock. So that's why it's really important to understand your biology, and if you're designed to go to 11 o'clock, it's going to be very difficult to fall asleep before that. That doesn't mean you necessarily have insomnia, it just means you don't understand your own biology. And if you click into your own biology, then your sleep will be a lot easier. Waking up during the night can be normal. It's not necessarily abnormal. If you look at the internal structure of sleep, it's not 8 hours of constant sleep. It is 1.5 hour bits, and at the end of each 1.5 hours, we're designed to wake up a little bit. And the feeling is, or the understanding is, that goes back to our very, very early origins, when we might be living in a cave, and it's not a good idea to be unconscious for 8 hours. That we're designed to wake up every hour and a half and just scan the environment. If the environment is fine, we go back to sleep. And it explains sometimes why we wake up and we go, something's wrong, and it takes us a couple of seconds to realize that the electricity's gone off. But the electricity went off half an hour ago, and we're kind of going, why did we only notice it now? And that is because now is your natural wake up. Now is when you scan the environment, and now you see the problem. So there are normal wake-ups. And you can wake up during the night, you can go to the bathroom, you can come back from that. But what is normal at that point is that you can go back to sleep. The abnormality would be waking up, coming back to bed, and then not being able to go back to sleep again. That would be a symptom of insomnia. So the waking up itself, not necessarily abnormal. But that's once or twice a night. If you're waking up 5 or 6 times a night, that's abnormal. And you shouldn't be doing that, even if you can go back to sleep again. And that may indicate that you have a deeper problem, and that may be sleep apnea or restless legs or something like that. So there's normal waking, and then there's abnormal waking. So it's important to understand the difference between the two. So let's look now at why we think that even looking at insomnia and treating insomnia is important. I mean, why do we care about not being able to sleep properly at night? Well, firstly, it is about your daytime function, and it is about the fact that if you are not sleeping well at night, you are unproductive during the day, if not, frankly, non-productive. So your productivity is low, particularly after lunch, where we have a natural low, so a natural kind of dip. And normally during that dip, you should be going, okay, I should not start a new project now, should not be doing any hard work. Let me just get through this dip and then I can do some hard work later on. But if you're not sleeping well, that dip can mean that you are frankly sitting there and going, I cannot do anything. I am so tired. I can't function. So immediate daytime dysfunction, that includes driving. I mean, you're not driving well. I'm sure many of you have had experiences of having had a bad night of sleep, driving in your car and kind of feeling like you have tunnel vision, because you drive, you get to where you're going to, and you kind of go, I don't know what happened during that drive. I know I got here safely. I know I was present to drive, but I couldn't remember anything. And that's what we call tunnel vision. That's a symptom of sleep deprivation, or the fact that you haven't slept well. So obviously you're more prone to have accidents during the day. And those could be car accidents, work accidents, accidents in the home, all kinds of accidents. You're more likely to have accidents. So there's the immediate kind of dysfunction that you have the next day. But what we as doctors are more concerned about is we're getting a lot of evidence now that if you have long-term insomnia, that you're more likely to get a whole lot of other stuff. And primarily, if you just think about it, what the function of sleep is to restore your body. You kind of work. If you think about that credit card thing, you pay on that, you spend on that credit card all day, you have to pay off at night, and that paying off is important. It's like servicing a car. You've got to service this car, your body, your mind. You have to service that every night, and you have to wake up refreshed. And if you underservice a car continuously, it's going to break down faster. And so that's what we're getting more evidence about, is all of those big diseases, be it diabetes, depression, dementia, heart disease, all of those diseases, if you have insomnia, are likely to occur earlier in life. So 5 years earlier or 10 years earlier in life, depending on how bad the underservicing is that you're having. And it doesn't just apply to insomnia, it applies to sleep apnea and every other sleep disorder as well. Those are the big consequences. So let's pick some of them to just look at. So depression, let's pick depression. So the relationship between insomnia and depression is very close. In that, if you have depression, 70 to 90% of patients who have depression are going to have insomnia as a symptom of the depression. But not only is it a symptom of the depression, it's going to make the depression a whole lot worse. Because if you have insomnia, and particularly if you lie in bed trying to fall asleep, and you're depressed, the thoughts that you have in your head are never good. They're always catastrophic. You just think about how awful your life is, and you wake up with all of those thoughts in your head. And so the insomnia itself can make the depressive symptoms during the day worse. But it's even more subtle than that. If you have insomnia from any cause whatsoever, even if it is just insomnia during exams at university, so you have what we call a stress-reactive insomnia, that you respond to stress with insomnia, you are more likely to get depression later on in life. And that lasts for the rest of your life. That risk lasts for the rest of your life. So just insomnia from any cause is likely to increase your risk of depression. So that's why we want to treat the insomnia, because we don't want you to get depression, because depression then flavors everything else and also increases your risk of all of the other diseases. So that's depression, very close relationship with insomnia. Then we have things like dementia. We have good evidence that if you have insomnia, long-standing insomnia, that you're more likely to have depression. And when I say more likely, I'm not talking about 50% chance of getting dementia. We're talking about a statistical risk, which might literally be an extra 2% on top of the current risk. So it's not a huge risk. Same thing with depression. It's an increased statistical risk, not 50% of people who have insomnia are going to get dementia. It's not that risk at all. So there is an increased risk. And that brings in this whole topic of the sleeping tablets, and the sleeping tablets increasing your risk of dementia. Well, it seems that overall, the information that we have about that is that insomnia increases your risk. If you look at the sleeping tablets, there is an increased risk. But the increased risk on sleeping tablets is not bigger than the increased risk of insomnia itself. So the sleeping tablets are not the most horrendous things in the world. They actually do help you sleep properly with insomnia, and they're not actually increasing the risk more than that just from insomnia. But there is an increased risk of that. There's a problem with pain. If you have pain and you don't sleep well, then you have an increased what we call sensitivity to pain the next day. So any current level of pain that you might have that you were able to cope with yesterday, if it's the same level today and you had a bad night last night, it's going to feel more painful during the day. So, and that's a really clear thing. The problem is that that level of pain during the day is then going to influence your sleep at night, so you're likely to sleep less at night and therefore have more pain during the day. So there's what we call a bidirectional relationship with pain and sleep. Worse sleep, more pain, worse sleep. And so it is really important to manage that cycle so that you can sleep better and reduce the level of pain that you have. The really interesting one is the relationship between weight and insomnia. So if you have long-standing insomnia, the chances of you being heavier is higher. And so we talk about the fact that with all of the sleep disorders, and the phrase we use or the measurement that we use for weight is BMI, and that's the relationship between weight and height. It's not perfect, but it's often used to look at, do you need to lose weight, and are you at a healthy weight? So if we look at BMI, you're more likely to have a higher BMI, i.e. be more overweight, if you don't sleep well. And again, that refers to every single sleep disorder, whether it's insomnia, chronic shift work, sleep apnea, restless legs, whichever sleep disorder you're talking about, you're more likely to be heavier. So there is a sense that you need to get your sleep better because your weight management is better. And so what that kind of tells us is that everything is thrown off if you don't sleep well. Your metabolism is thrown off, your brain function is thrown off, everything is thrown off. And so we want people to sleep better. We don't want people to have to suffer with insomnia. So what are the causes of insomnia? Well, I think most people can identify with stress as a cause of insomnia. Whether it's exam stress, whether it's one of those big life stress events, moving house, getting divorced, death in the family, children leaving home, retiring, whatever it is, those are all stresses. And so I think we can all identify with the fact that if we're stressed, we find it more difficult to sleep. But in most people, those stresses are temporary. And so sleep goes a little bit for a couple of days and then it comes back again. And that is called acute insomnia, or it's called transient insomnia, or short-term insomnia. See, the problem with medicine is that as it goes along, we change the names of disorders. And that's very confusing for everybody, including doctors. So we always used to call this acute insomnia. It's now called short-term insomnia. So we have to change that in our heads as well. So that's why you may see it called different things. It's the same thing fundamentally, right? So it's just about stress causing insomnia for a couple of days. But we all know of situations where people can be stressed for much longer. And that could be work stress that carries on for much longer. It can be the stress of a parent who is concerned about a child that has a chronic illness. That kind of stress is going to last for longer. So stress can be a cause of short-term insomnia. It can also be a cause of long-term insomnia. And that is what we would call an environmental cause of insomnia. There are many environmental causes of insomnia. Stress is one of them. Another environmental cause being too hot, being too cold, too much noise, too much light. All of those are environmental causes of insomnia. They tend not to be, the kind of light, dark thing tends not to be a cause of chronic insomnia, but often makes other causes of insomnia much worse. So we have stress causing acute insomnia, and then we have environmental causes. Then let's look at the chronic insomnia. So there are medical causes of chronic insomnia. There are diseases that can cause insomnia, particularly those that cause pain. So rheumatoid arthritis, fibromyalgia, anything that causes chronic pain is likely to cause insomnia. But also things like asthma. So if you're waking up in the middle of the night battling to breathe, if you have heart failure and you find that it's really difficult to lie flat because there's a problem with breathing, all of those kind of things can cause insomnia. So lots of medical causes for insomnia. And the problem with medical diseases as well is that we give you treatment for them. So we put you on medication. And a lot of those medications can then cause insomnia as well. And the big ones that do that are cortisone. So if you're on cortisone for anything, particularly asthma, you tend to get put on cortisone. All the autoimmune diseases, often you have courses of cortisone that you get put on. Cortisone is a very bad interrupter of sleep and can really throw your sleep off, as well as make you put on weight, which often causes you to snore and have apnea. So there are many consequences to being on things like cortisone. But also antiretrovirals. So the older antiretrovirals used to cause a massive disruption to sleep. It looks like the newer ones are much safer and give you much better sleep, which is good news. Things like cholesterol agents, so what we call the statins. Some of them can cause interruptions. Some patients don't have interruptions in sleep, some do from the cholesterol agents. Things like beta blockers. There's lots of medications. In fact, there's a list of 184 medicines that list insomnia as a side effect. That also includes the antidepressants, which are supposed to be improving insomnia. So often patients will say, I don't understand how I'm taking an antidepressant to improve my insomnia, but it lists insomnia as a side effect. Well, please remember when we look at that list of side effects, that when it comes to legislation, if that side effect happens in 2 people in the world, it has to be listed. Okay, so the problem with those side effects is it doesn't tell you how likely you are to get that side effect. And that's the problem. And often most of the side effects that are listed for medications, you're very unlikely to get those side effects. There are big ones, and then common ones, and then there are rare ones. And so in the antidepressants, for example, it is quite rare for patients who are treated well on an antidepressant to have insomnia as a side effect. But it was reported, so it has to be listed. Okay. Then we look at the big psychiatric disorders. Pretty much most people who have anxiety or anxiety disorder, or who have depression, or who have ADHD, or who have autism spectrum disorder. So all of those patients are very likely to have insomnia as part of that disorder. In some of the disorders, the insomnia is biological. So, for example, in autism spectrum disorder, we know that that's possibly due to a low melatonin, and supplementing melatonin in those children or adults makes their sleep a whole lot better. In some it's biological, in other it's related to that disorder. In some patients, it's just that the two things coincide. So they have anxiety, and they also have insomnia from something else, and they coincide. So they're not necessarily linked. And why that's important is because you may have depression and insomnia, and you may find that you're on an antidepressant and the depression is well managed, but the insomnia continues. And that insomnia may be from something else now. So it may not be from the depression itself. So psychiatric diseases, really important to find them and manage them properly, because it may be a cause of insomnia, but not necessarily, and that's really important to remember. Then we have the big sleep disorders. So the medical sleep disorders that are really big triggers for insomnia. So the first one of those is the circadian disorders, and that is all the disorders related to a problem with melatonin. And there are a number of them. And as I said, I'm going to do another podcast on melatonin itself and these disorders specifically, because they're really important. But things like teenagers who go to bed very late, so they shift their whole sleep cycle into another time zone, and they can only fall asleep now at 2 o'clock in the morning and wake up would prefer to wake up at 10 and sleep very normally, as long as their sleep is on the other side of the Atlantic, then they can sleep very well. But they have huge difficulty in falling asleep, and they would be diagnosed with insomnia, but there's a biological cause for that, and that's about the melatonin. I've mentioned the autism spectrum disorder, problems with melatonin, and so multiple reasons why you might have a melatonin issue with your sleep. And obviously the treatment for that would be melatonin. Then there's restless leg syndrome, and I've done a whole podcast on restless leg syndrome. Please go and listen to it if you think you might have it. And it's really described as being uncomfortable before you fall asleep, feeling an urge to move, that you can't lie still. It may not happen before you go to sleep. It may happen in the middle of the night when you wake up. Really interrogate yourself when you're trying to fall asleep, and if you have difficulty falling asleep, and say, why am I having difficulty falling asleep? Am I not sleepy? Is it because I can't get comfortable? And if it's because you can't get comfortable, please go and see your doctor and ask them, do I have restless leg syndrome? Because if you have restless leg syndrome, then trying to fix the insomnia without fixing that is going to lead to failure. And I have seen many patients who have tried all kinds of things to fix their insomnia. And when we have this conversation, they go, actually, I think I do have that. My mom had it, and I have it, and I think my daughter has it. So really important to find these big biological disorders. Then the last one is sleep apnea as the big biological disorder. And most people would think of sleep apnea that it really happens in men who are over the age of 50, who kind of overweight, and they tend to sleep quite well, wake up really tired in the morning, and then are sleepy during the day. That is the typical sleep apnea. Well, it turns out that that's only about half of men who have sleep apnea present like that. The other half are split between men who have very few symptoms at all, and in fact are really surprised when you do a sleep test and they come up with really severe apnea, because as far as they were concerned, they were sleeping just fine and perfectly functional during the day. The other group of 25% of men are going to present with insomnia. And why they present with insomnia is because with sleep apnea, you get an awakening from sleep to restart breathing or restart airflow. So you get an awakening from sleep, and often patients wake up with an adrenaline surge. So they wake up with their heart beating very quickly, feeling like they've had a panic attack while they're asleep, sweating, and then find it very difficult to fall asleep after that, partly because they're saying, I don't know what happened, but that was freaky. And then may find it difficult to fall asleep after that. They wake frequently. So remember, I spoke about people who waking 5 or 6 times a night. Those are the kind of people who are likely to have sleep apnea. They're going to wake often because of the apnea. The apnea is going on 20 times an hour, and so there's lots of opportunity to wake and be aware of being awake during the night. And so we do want to find patients who have sleep apnea and those patients who present with insomnia, because it's not an immediate jump that you would do to go, oh, I have difficulty sleeping at night. I'm okay falling asleep, but I wake up at night and then I battle to go back to sleep again because I feel like I've woken with a start. So in that group is to say, like, do I snore? Because if I snore, then there's a chance that I have sleep apnea, which is actually producing these wake-ups during the night. So those are the big sleep disorders, right? So we've done the environmental ones, we've looked at the psychiatric disorders, we've looked at the big sleep disorders. And then there are a lot of patients who come and see me and go, I have no idea why I can't sleep. There's nothing wrong. They don't have restless legs. They don't have sleep apnea. They don't have a problem with their melatonin. They just battle to sleep. And those are the patients that we term that they have insomnia disorder. It's a standalone, it's keeping itself going, and that is insomnia disorder. And that's a really interesting disorder, and the majority of people that I see have that disorder. So let's talk about that. Where does it come from? It often starts with that stress. So often patients will say, it happened after I got retrenched, or it started after this. And in that moment, when you are retrenched or when someone in the family passes away, you have acute insomnia, as we mentioned. But if you have acute insomnia, what we know about that acute insomnia, 75% of people who have acute insomnia are going to start sleeping normally again. And so they're just going to carry on and they're going to be fine. But there's that 25% of people who won't be fine. And what happens in that group of people is when they have that acute stress, so when you're in that acute stress, you're very aware of why you can't sleep. I can't sleep because I'm worried about this, whatever that is. So you're in that kind of zone. But during that process, and if the stress goes on for a little bit too long, and that might be 2-3 weeks, that's all it takes to have this change happen to become this independent disorder and insomnia disorder, which can then last for decades. In that process, what happens is you start to get worried about your sleep. So independently of the worry that you have about the stress, you now start to worry about your sleep and have thoughts that go like this. I hope I fall asleep tonight because I didn't sleep well and I haven't been sleeping well and I hope I fall asleep. Now, the minute you get anxious about your sleep, there's some changes that happen. Firstly, if you remember about how we fall asleep, be safe, be comfortable, let go. The minute you start to be anxious about your sleep, it's really hard to let go. You can be sleepy, you can be safe, you can be comfortable, really hard to let go. And often patients describe that as their head is just running. They describe it as if I could just switch my head off, I would be able to fall asleep. And that is what we call the racing mind. And that is what often creates this insomnia. And then that creates the insomnia. Then you have insomnia, and then the next night when you go to bed, you're anxious about your sleep because you didn't sleep well last night, and that creates another night of insomnia, and so on, and so on, and so on. And it just keeps itself running. So, but there are multiple components that happen after that. So that's the initial trigger for you to start having a bad night every night for no reason except that you're worried now about your sleep. So the worry about your sleep is what's making you not sleep. And you can see that that's a very kind of sick game that you're not going to win. If you worry about your sleep, you're likely to have a bad night. And then the next night when you try to go to bed, you're going to be anxious about your sleep. Now, this anxiety that you have about sleep is very different to anxiety disorder, where you're just anxious. This is a valid anxiety. You're right. You are going to have difficulty sleeping because of this anxiety, but the anxiety is correct. So what happens after that? So in that process, kind of 2-3 weeks into this process where you're having anxiety about sleep, what you start to do is look for a reason. And so that's where the light and the dark environmental things start to be an issue. Maybe it's because of the light that I can't sleep. Maybe it's because of the sound that I can't sleep. So we have people turning their alarm clocks away from the bed, putting a little masking tape over the little green light that's sitting on the phone charger or some other charger, covering all of those lights because they interfere with me falling asleep. Well, they don't, but you're now looking for causes to fall asleep. The big cause is if you have a partner who snores and you're lying there trying to fall asleep and they start snoring and you feel this rage about the fact that they're snoring. And that, before you started this process and, a year ago when you were sleeping well, that would never have bothered you. But now it bothers you in a way that's different. So you have changed. Your thinking process has changed and the way you think about sleep has changed. So your thinking changes. It's really hard to relax and fall asleep. And then you generally do put behaviors in that make it harder to sleep. They sound logical when you're doing them, but we know that they don't actually help you fall asleep. And the two big things that people with insomnia do is, firstly, they spend longer in bed. And that sounds perfectly logical. If I'm going to bed at 10 and getting up at 6, and I can only get 4 hours or 6 hours of sleep in that time zone, then what I'm going to do is I'm going to go to bed an hour earlier because then I'm likely to get more sleep. So that sounds very logical that that's the way sleep is going to work. It just doesn't work like that. If you do that, you are likely to spend more time awake. You might get an extra 20 minutes of sleep, but not the amount that you're getting because you're going to spend more time awake because of that anxiety.
You've been listening to another production from Solid Gold Podcasts.